Hello, and thank you for joining this OncLive Peer Exchange titled New Treatment Paradigms for Advanced Melanoma. During the past several years, the availability of immuno-oncology agents and mutation-targeted therapies has transformed the way we treat advanced melanoma. As medical oncologists, we're bombarded by new and exciting data, often providing multiple choices for treating the patient that's sitting in front of us. In this OncLive Peer Exchange discussion, I'm joined by leaders in the field of melanoma clinical research. Our goal is to provide you with clinical context surrounding the data to better inform your treatment decisions. In today's discussion, we'll explore some of the important research coming out of the 2018 ASCO annual meeting. We'll focus on the latest information surrounding the use of adjuvant therapy, as well as new options for the treatment of metastatic disease. I'm Dr. Jeffrey Weber, Deputy Director of the Laura and Isaac Perlmutter Cancer Center and Professor of Medicine at NYU Langone Medical Center in New York City. Participating today on our distinguished panel are Dr. Robert Andtbacka, Professor in the Department of Surgery at the University of Utah School of Medicine and investigator at the Huntsman Cancer Institute in Salt Lake City, Utah; Dr. Omid Hamid, Chief of Research in Immuno-Oncology at the Angeles Clinic and Research Institute and co-director of the Cutaneous Malignancy Program at Cedars-Sinai Medical Center in Los Angeles, California; Dr. Jason Luke, Assistant Professor of Medicine and Medical Oncologist at the University of Chicago in Chicago, Illinois; and Dr. Michael Pastow, Assistant Attending Physician in the Melanoma Immunotherapeutics Oncology Service at the Memorial Sloan Kettering Cancer Center in New York City; and Dr. Hussein Taubi, Associate Professor and Director of Clinical Research and Early Drug Development in the Department of Melanoma Medical Oncology, and also a member of the Department of Investigational Cancer Therapeutics at the UT/MD Anderson Cancer Center in Houston, Texas. Thank you all for joining us, and let's begin. There's been an awful lot of action and a lot of research and development in the adjuvant field in melanoma in the last year, with 3 very impressive trials and multiple new approvals. This brings up a host of issues, and one of the first issues we think about is who gets operated on and who doesn't, who then gets adjuvant therapy. So Robert, how do you decide what are the criteria for resecting a patient who has either stage 3 or stage 4 melanoma? Who's resectable and who's not?
It's a very good question, Jeff, and something that we deal with every day in our practice of patients. I think we really, in the stage 3 setting, we really have to divide patients into the ones that have microscopic disease in their lymph nodes versus the patients that present with bulky disease and macroscopic disease. So first, if we look at the patients with microscopic disease, had we had this discussion about a year ago, we would have recommended that pretty much all patients, if they have microscopic disease in the lymph node basins, that they get a completion lymph node dissection. Now, there are 2 important studies that have presented results asking the question, do we really need to do that? And in those studies, patients were randomized to either have a completion lymph node dissection, which would have been the standard of care, compared to ultrasound follow-up if they had of the lymph node basin. Now, both of these studies looked at the survival in the patients, slightly different types of survivals. The MSLT2 study, which was the larger one of them, looked at melanoma-specific survival. And there really was no difference in the patients who had a positive sentinel lymph node and underwent the completion lymph node dissection versus had an ultrasound follow-up in melanoma-specific survival in that patient population. Now, we have to remember, though, that the only patients who really benefit from surgery, from additional surgery if they have a positive sentinel lymph node, are the patients with additional disease in their lymph node basins. And they account for about 25% of all patients. So that means that 75% of patients would not have benefited from this operation at all. Now, the second study was a German study, a slightly smaller study, but also looked at distant metastases-free survival for these patients and sort of similar patient population. Again, there was no difference in survival for those patients. Now, one of the caveats with both of these studies that the amount of tumor in the sentinel lymph node was fairly small. So we have to remember that when we think about these patients, that most patients only had 1 positive sentinel lymph node, and when we did a completion node dissection, did not necessarily find additional lymph nodes with melanoma in them, and the tumor burden in those sentinel lymph nodes was quite small. So I think that in my practice in these patients, I still think is following these patients with an ultrasound is a very viable option, and I would say more than half of the patients wish to follow with an ultrasound only.
How often do you do it?
So I would say in my practice, we probably do it about 20 to 30% of the time we do a completion lymph node dissection. And it tends to be for the patients that present with a large amount of disease in the lymph node basin. and also for patients with multiple lymph nodes with melanoma in them. I still think that that remains controversial. Now, we know that in these patients, after we've done that completion lymph node dissection, they have a high risk of local recurrence, but also of distant recurrence. And these are patients that we would always discuss adjuvant treatment with. And the adjuvant studies that have been done, in those studies, all patients who went on the adjuvant studies had to have a completion lymph node dissection. So I think one of the controversies is that we don't fully know what the benefit of the adjuvant therapy is if the patients have not had that completion lymph node dissection. Having said that, I think that still the minority of our patients now get a completion lymph node dissection.
And interestingly, I don't think there's ever going to be an adjuvant study in patients in that category, given that we have multiple positive studies, which we'll talk about in a few minutes. I don't think that's ever going to happen. So as often happens in medicine, we use the best data we have available, and we'll be extrapolating